Good morning, good afternoon. My name is Nicola Bedlington, and I have the honour and pleasure of moderating today's parallel session focused on shared decision-making in heart valve disease. The objectives of the session are to raise awareness about shared decision-making between patients and clinicians, and of course its importance in heart valve diseases. This is in the light of the work undertaken by the Global Heart Hub and its Heart Valve Council following the publication of the updated ESC guidelines, and that work of the Global Heart Hub is continuing into next year. We have 4 fantastic leaders in the field with us today who will share their experience and knowledge, but there will be time for a Q&A after our initial conversation, and please do add your questions to the Summit platform on an ongoing basis. Please use the Q&A tab, not the chat, and we will try to address as many of your questions as possible. So without further ado, let me kick off by introducing Dr. Nina Ajmon-Marsan, a senior cardiologist, an expert in valvular heart disease and CVD imaging, from Leiden University Medical Center in the Netherlands. Nina, a very warm welcome to you. Given your vast experience, could you give us a brief glimpse of heart valve disease and the patient journey from your perspective as a leading professional in the field?
Thank you, Nicola. It's really a pleasure for me to participate and actually to discuss this. I believe is really a crucial topic because, as you know, valvular heart disease is one of the most common cardiovascular disease worldwide, and patients with the valvular heart disease are limited by important symptoms and unfortunately also a higher risk of dying. And what is very peculiar of valvular heart disease is that this, if we compare, for example, coronary disease, myocardial infarction, even heart failure, for this disease, there is not one single medication that has proven to stop the progression of the disease or even avoid, which are the common cardiovascular events, such as developing of arrhythmias or heart failure. So we have medication that can mitigate the symptoms, but they cannot treat the disease. So the only option for these patients is actually undergoing an interventions, either surgical or percutaneous, that means via catheter. So the journey of the patient starts obviously with the diagnosis of valvular heart disease. So the role of the cardiologist is, of course, to explain well what that means, and that if it's not severe, it only implies that it should be followed up regularly to see the evolution of the disease. But when it becomes severe, and potentially with symptoms and with signs of decreased cardiac performance, let's say, then is the moment that the patient has to undergo indeed an intervention. And the guidelines that you just mentioned give us a very clear algorithm how and when we should give this indication. But as you know, each patient is different, has a specific situation, needs, wishes. And luckily, the guidelines recognize this problem, and they recognize the crucial role of what we call the heart team, which is a core team of the specialists involved in valvular disease. So the cardiologist, the interventional cardiologist, the surgeon, and the specialist in imaging, and eventually also the geriatrician or other possible specialists involved, which discuss together each and single patient, taking into account not only the bold information coming from the cardiovascular tests, but really the psychological, social, and all physical aspect of the single patient, because of course we can have a young patient that needs to be active and sportive, or a very old patient that instead is very fragile and has multiple comorbidities. So this is really a crucial moment where unfortunately the patient at that moment is not involved, but the treating physician that participate to the heart team has to upfront discuss and collect the wishes and the characteristic of the patient so that the team can take the best decision for the best solution. And whatever the solution is of course, as I said, the only one is an intervention, which represents for the patient a very dramatic moment. Obviously, is the only solution, but is quite a traumatic moment. And also, it kind of introduces a new form of disease in the terms that after the operation, of course, the patient still has to be followed up with regular checkups, needs medication, for example, anticoagulation, and has to have some lifestyle adjustment measures like to avoid endocarditis, infection, and these kind of things. So the journey of the patient certainly doesn't stop with the intervention, but just changes course. And we as cardiologists, we are responsible for the patient. We have to really build a trust relationship that, of course, starts with the diagnosis as a very big moment of shared decision making at the moment of the intervention, but afterwards as well continues to be very important. And I put a bit the hat also of a bit educator, because I'm chair of the education committee of the CVI and also in the committee of ESC. And there's been a lot of discussion of how we can eventually prepare materials really dedicated for the patients that explain the disease, but also the test that the patient has to undergo to prepare for the intervention, such as an echocardiography, sometimes through the transesophageal, CT scan, angiography, all kind of tests that can, of course, be scary for the patient. Then, of course, the moment of the intervention and the follow-up. So I think it's important to prepare this material because, unfortunately, we as physicians, sometimes we lack the time for a very long discussion with the patient. And if the patient comes already prepared with the official material, we can discuss each of these moments in the most appropriate way. So as to final answer to your question, I hope I give you a little bit our impression of the patient journeys goes and how he just changes course in every step of his history.
Thank you very much, Nina. You've raised so many really key topics, the importance of a holistic approach, the trust factor, which of course is absolutely critical, education, health literacy, focusing on the needs of the goals of individual patients, which of course differ, and the role of the heart team. Thank you very much for that. Fantastic. And I'll bring you in a little later on to go into a little bit more depth on a couple of those topics. It's now my pleasure to introduce Dr. Sandra Lauk, who is nurse clinician scientist from Canada. Sandra, you're an expert on shared decision making and contributed significantly to the Global Heart Hub's work in the area. We're delighted to have you here with us today. In a nutshell, Sandra, can you tell us what shared decision making is all about? Why is it important to our community, the heart valve disease community? And how can we perhaps embed it better in health systems? So over to you, Sandra, and I know that you'll be sharing a few slides.
Thank you, Nicola. And Nina, thank you for setting the stage, I think, to really prepare people to engage in that conversation. So I'm tasked with talking about what shared decision making actually is. So let's look at a patient so here's Mrs. R. She's a 76-year-old, and she's maybe coming to see Nina here. She's recently developed symptoms of severe aortic stenosis, and she's otherwise healthy and fit. And as we've heard, there is no medication to cure this, and it has to be considered for an intervention. So her cardiologist refers her to the surgeon for evaluation for a valve replacement. And as Nina nicely presented, the treatment options include either a surgical approach or something that can be done with a catheter, so a hollow plastic tube, so something like transcatheter aortic valve implantation or TAVI. So there is the clinical expertise. So physicians and healthcare providers really ground their decision on evidence. So what does the data say? What does science tell us? So she knows that Mrs. R's risk for cardiac surgery is low. She's less than 80 years old. She's robust. She has good renal and pulmonary function, so her systems work well. She's also thinking as a clinician, as an expert in this field, that there's limited data, for example, on long-term durability of some of the valves, and thinking that in this case, Mrs. R is that surgical AVR might provide a better long-term outcome until we know more data. So that is that clinical expertise side of it, but there's also the lived experience expertise. And in this case, Mrs. R, what's maybe going through her mind is, my husband was diagnosed with dementia last year. I worry that if I take 2 to 4 months off to recover, if I cannot drive for a while because of the chest incision, if I cannot be there, what will happen to him? Will this tip him over then into needing care? And what matters most to me is to feel better as soon as possible, and the time I still have with my husband. So that is a different view on expertise. So what is shared decision making? It really is, I think, a response to what most patients want. They want to be offered an informed choice. They want information about the risk and benefits of each option, but most importantly, they want to be asked about what some of their preferences, values, and priorities are. So what then defines shared decision-making? First of all, is that two-way process between healthcare providers and patients to achieve a good treatment decision. It's an invitation to patients, and it's an information exchange that then considers that patient expertise. Because ultimately, it is about sharing equally important expertise that comes from these different perspectives. So why is it important? Well, we have increasing evidence that it is a very good thing to do, not just for clinician-reported outcomes, but also for patient-reported outcomes. We know that the implementation of shared decision-making gives patients a greater sense of control over their illness. It improves communication with the healthcare team, increases patient engagement and satisfaction with care, which we know are associated with improved outcomes. It decreases the concerns of illness, and importantly, it decreases decisional conflict. So that sense of, I wish I had known that, and decisional regret and uncertainty. So just a few things about how can we get better at doing shared decision-making, because from my perspective, there's a real gap between the good intentions of the guidelines that Nina talked about and actually implementing some of these interventions. So it starts with the assessment to empower the patient and to invite the participation of the patient and their family in shared decision-making. And I think we all recognize that people want to play different roles, ranging from a very active role, such as I prefer to make the decision about which treatment I will receive, so that highly engaged, highly informed, and highly expert patient who wants to really be part of that, versus, a more passive role. I prefer to leave all decisions regarding treatment to my doctor. There's no right or wrong in there, but I think there's ways of then measuring how effective that engagement needs to be from the patient. There is then presenting the treatment options, so such as saying we have a decision to make about how to best treat your condition. These are the options that we have to treat your condition, because not all options are available for every patient. And these are some of the risks and benefits of these options for you in particular. And then that engagement about, tell me what matters most to you and how we treat your condition. So that invitation to knowledge exchange, and the elicitation then of values of preferences. And then ultimately trying to figure out, all right, given what your goals of care are, what we need to think about is, so the feasibility, the risk, and the benefits that are associated with that individual. And ultimately coming to that statement about, given what we have discussed and what is most important to you, what is your preferred choice and of how we can best treat your condition? Again, based on what is available for that patient and given their individual circumstances, and then being able to conclude then with that, reaching that good treatment decision. So as I said, I think there's a real gap between these good intentions and these improved outcomes. And this is a paper that we published recently that speaks to that, and wanting to have then set the scene for this conversation. So thank you very much.
Thank you, Sandra. Again, you raised so many really important topics, this idea of equal expertise in the dialogue between the patient and the clinician, the importance of informed choice, preferences, values, priorities, and the fact that empowerment isn't necessarily linear and differs enormously with the individual patient, but at different stages of his or her journey. Fantastic. And again, we'll come back to go into a little bit more depth on a couple of things you raised. I'd like to now move to a patient's perspective and a warm introduction to Sandra McGonigal, who is a patient advocate from Ireland. Sandra, thank you so much for being with us today and sharing your own personal experiences. And I know from earlier calls, you're absolutely passionate about empowerment, patient's choice, the importance of accessible quality information to make that choice. It would be wonderful if you could share some of your thoughts on all of this and share decision making, again, based on your story and your experience.
That's great. Thank you, Nicola. And I'm delighted to be here to speak from the patient's perspective. I had an aortic valve replacement back in March 2021. And due to my age, I was offered a particular treatment option, which didn't really suit my lifestyle. And I had a personal opinion around that treatment option as well. So I really kind of wanted to explore other treatment options. And I really wanted a choice, I guess, in terms of what treatment I received. So through discussion with my cardiologist, I was very open and honest and had said how I had felt about the treatment option that was offered to me. I had kind of carried out my own personal research, sought out information from various different online communities, and learned of other options open to me. So I took this back to the cardiologist and explored those with him. So I guess it was a three-way thing really between myself, the cardiologist, and the thoracic surgeon. We kind of came to a shared decision regarding the best treatment option for me, kind of weighing up, as Sandra already mentioned there, the kind of the risks and the benefits. And then we made the decision regarding the best treatment option for me.
Great. And just an extra question here. How assertive do you feel you had to be in the dialogue, that three-way dialogue you've referred to?
Initially, quite assertive. I guess because of my age at the time, 45, according to the NICE guidelines, which would suggest a particular type of valve. But I was pretty adamant that was the valve choice I did not want. So I did reach out to the online community. I did reach out to kind of experts in this field to try and source information. And I guess when I had that information gathered, I was able to put that information together and then kind of approach the cardiologist. It did take a few consults, I'll admit, but the more consults we had, and the more the open and the honesty within the conversation, that definitely did help the process. And I do feel in the end we got there and I did feel supported around my choice.
Fantastic. And again, you've raised a couple of really important points that were alluded to earlier, the role of personal research, thorough research on the part of the patient, and addressing that in a very clear way, but also the issue of trust and honesty and openness. Thanks. We'll come back in a few minutes to you. Let's move to our final panelist then, Jodie Smith, who is the Programme Director at Mended Hearts, which is a powerful patient organisation in the US. Jodie, a warm welcome to you as well, and thank you for joining us today. So based on your experience and Mended Hearts work, what do you see as the role of patient organisations generally in advancing shared decision making?
Thank you, Nicole. And patient advocacy organizations play a very important role. Philosopher Lao Tzu said, "Give a man a fish and you feed him for a day. Teach him to fish and you feed him for a lifetime." So I see the role of patient advocacy organizations as teaching to fish, the empowerment that was brought up earlier. Empowerment is essential. And when you have empowered patients, they can and will often engage, like Sandra, in shared decision making. But first, they have to be empowered. They have to have that information. The first thing that patient advocacy organizations can help people do is take control. A lot of times when we have a disease, we start as a victim, in a victim mentality. And patient advocacy organizations can take people out of that victimhood and teach them, show them, because they're made up of the patients themselves, how that people can take control of their condition. They can take charge. It's their journey. The decisions that are made affect them and their life. Other people can't make those decisions for you and have them be the best decisions for you. And then the second thing that we need to do is the education and awareness piece that you heard of earlier. It is essential that people have reliable education about the disease itself, treatment options available, as you heard Sandra just say, and the risk and benefits of each treatment option. And this can be difficult for people to find reliable information. There's so much out there. So advocacy organizations can take this information and put it together so patients can understand it and digest it and use it. The burden should not be on the patient to figure out to figure this out themselves. And we've seen on the breaks a lot of wonderful resources from different organizations. And one of the things that people have to be able to do is put those resources out there so people can access them. And then they also must know their rights as a patient. They must be able to get information. One of the beauties of a peer support or a patient advocacy organization is they can help people know what questions to ask. They can normalize, because they show the patient perspective, they can normalize the feelings and opinions and ideas that patients have, and they can help guide and navigate conversations that patients can have with healthcare professionals. They also help the patient be part of the team. In the past, a lot of care was like the passive model that Sandra showed. People were in the passive mind frame, but to be able to move out of it, that is to be able to understand that you have a role to play in this decision, and it affects, again, your life. And so we want to show patients how to share their voice. What are your preferences? What's your health goal? What are your needs? What are your wants? And then normalize that. This is the way you can be part of the healthcare team. And finally, to help them make decisions that are right for them, and show them how, if they make a wrong decision and it doesn't work for them, you can change your mind. You have the right to make a different decision. But we have to be powerful and work all together to help patients be empowered and be stronger in their decisions. And this is it's a big job. And a lot of people tend to be scared to take that role. I really admire what Sandra was telling. She's like, this is not right for me. I do not want this decision. And she stood up for herself. But how many people don't? And they go with a decision that wasn't right for them. And then there are pretty significant consequences from that, both mentally, emotionally, and physically for that.
Super. Well, again, some really, really important themes and common themes emerging. Obviously, the role of empowerment, moving from a sort of victim mentality, the value of peer support that you get from a patient organisation, seeking out reliable, trustworthy, accessible information. And it's great you brought the patient's rights perspective to the fore as well, but also that the patient being part, intrinsic to the care team is another important message as well. So we've heard various perspectives, and in fact, a lot of alignment in terms of the importance of shared decision making for patients, heart valve disease patients, in actually acquiring their goals and actually getting the outcomes that really matter to them. I'd now like to open up to a panel discussion and again invite participants to put forward any questions that you may have that have come to your mind listening to our wonderful panel earlier on today. But let's kick off in any case with a question back to Sandra Lauk. You alluded to cultural change, Sandra. How do you think we can foster that more effectively and more systematically, if you like? What could be the key drivers, do you think?
Well, I think we need Jody and Sandra McGonigal to do a world tour, actually, and just get things sorted out for us, because I think that would go a long ways. But I think in terms of culture change, I don't think we can underestimate how difficult this process is for clinicians, and how much it represents how much it requires the acquisition of new skills. And new kind of clinical competencies. And I think we have a lot of work to do to study the implementation, like how to do this properly in a way that really meets the local context of care. So I don't think shared decision-making is a cookie cutter approach. It really is tailored to the local environment and to the clinical needs. So I think the giving healthcare providers and the skill set to do it, and I think ensuring that there is a mind shift, that patients are true partners in some of the work that we do. And I think that is a big culture shift. And it is about looking at healthcare not so much as clinician driven and as patient centered. And we have been trying to do this for most of my career, and we are still not there. So I don't think, and we don't have all of the answers, but there has to be, I think, as you said, Jody, that dogged determination to really push the boundaries and to say this is now a standard of care. The guidelines give us that. They are the stick. We have to create some kinds of, sense of why this needs to happen at a local level. So I think that's one thing. The second piece, I think, as both Sandra and Jody alluded to, is the availability of high quality resources. I really like that line about, patients should not have to figure this out. And I think it bodes on us to give them resources. So, for example, the emergence of patient decision aids, which again, I think really have to be tailored to the various countries, languages, and cultures, but to make sure that we give those types of resources. So I think that's a second piece. And I think the third piece is the work that many in this room are doing around empowering patients. And that again is that third culture shift.
Terrific, Sandra. I'll come back a little bit on another question on diversity, equity, inclusion a little bit later on in the conversation, because that sprung to mind as you were talking. The value of quality resources. Judy, can I jump back to you for a moment? Obviously, Mended Hearts are doing a huge amount providing these resources. What sort of feedback are you getting from patients on the value of these in helping them and supporting them in shared decision making? Have you done any sort of evaluation on how that's moving, how that's shifting the needle for individual patients?
Well, what we see on our end, so for example, as Sandra was just saying, the discussion guides, the guiding the conversation, we have discussion guides. And what we know is without having done surveys or extensive research on the people who use them, is they fly out the door. So we have printed versions and online versions. And we last year we did 10,000 of the printed versions just flew out the door, and a lot of them were brand new, so we didn't even have them out yet. So that we're seeing the use of them, and people really like them. They're little trifold, they're easy to understand, easy to use. So we know that people use those and the online guides and the other resources. And we hear anecdotally all the time how much they made a difference and how much they help people understand their disease and the treatment options. But one of the things we just did was it's called a visiting vignette. We try to do them monthly, and it's just a 25-minute little discussion of the patient perspective, much like what Sandra just did. And we did one yesterday with a patient who had a heart transplant. And the engagement of the people watching those is huge. We can't get to all the questions, and people are chatting in the chat box, and they're just engaging with them in a way that you can tell they're so relieved to finally have someone say, yeah, this is what I experienced, this is what I felt, this is what this is like. And just being able to feel more empowered by that and normalizing those feelings and experiences, and then saying what she did to help herself and what advice she gave. It was really powerful.
Fantastic. Great. Moving to Nina, back to Nina. So we've heard about how patients should prepare and feel empowered to ask questions in a respectful manner. Do you feel that clinicians are encouraging this type of interaction and are open, in fact, to the process? And what can be done to ensure that this important discussion takes place in a really effective way where both the clinician and the patient feel good about it?
Well, it's indeed a very difficult question, and I'm very happy that Sandra and Jody also highlighted that for the clinician, it's actually difficult because of culture. So there are different clinicians. I feel I'm quite modern in that, but many colleagues still have to have some culture shift, that for sure. But for us, it's sometimes difficult also in a daily activity. So, for example, it is a very simple problem, but we sometimes don't have the time to speak enough with the patient. So we are in heart valve center. This is the core of our activity, and still my outpatient clinic is 15 minutes per patient, which means speaking 2 minutes about the feelings and then no much time for anything else. So what I now implemented, and I think is something that should be routine in every center that does this kind of intervention, is to take a dedicated moment where you have at least half an hour where indeed the major steps, mainly the interventions, are discussed. And what I do for myself, because sometimes it's difficult to do, is to structure it. So to go point by point on the major decisions. So for example, for Sandra, I understand that was more an issue of deciding what kind of prosthesis, for example, should be used. And that is a detail, but is a very important one. It should take a lot of time. But for me, normally it starts, okay, why we're doing this? Do you understand that it's necessary and why? Because for us, this decision is not just based on yes or no, it's just on percentage. So we decide to do it because studies have said that if we do it, you have a higher percentage of better results. But there is the other percentage that is not at zero. So I like to explain that I decide to do that because of these reasons, but there is still the option of not doing it. And sometimes seems too early because the patient has no symptoms or doesn't understand why he needs something, and sometimes it seems too late, has been forgotten so far, and he arrives too late at the moment of intervention, has higher risk. Then indeed, what kind of intervention, why we would choose for one or another one. And even within the same intervention, what kind of intervention, a repair, a replacement, if a replacement, which prosthesis. So it's a lot of things to go through. Also after the intervention, which are the short-term risk, what you can expect in the first 30 days, and the long term, what is your expectation? You want to improve your symptoms, or you're very more like you improve quality of life or time of life. So there are so many points to discuss that we try to structurize and go through each of them. And this is why I said it would be great if the patients arrived, as Jody said, prepared. So for each of these pointers, maybe some questions, and we can go through it in a very systematic way and try to answer all of them. And for me, it's very important that they understand that also our decision is made on percentage. So it has always option to change.
Yeah. No, that's really interesting, and it actually alludes to some of the great work that the Global Heart Hub is actually moving forward on in the kind of tools that will be really very practical. We have a question actually specifically to Sandra McGonigal. Your doctor would have recommended the generally accepted HVD treatment for your age. When you sought to explore another treatment option, what was his resistance or her resistance, and what was really the winning argument that convinced them to accept another treatment choice? So how did you convince them?
I guess they were guided by the NICE guidelines, and the NICE guidelines would suggest for a patient of my age that a particular valve was the best treatment option. I hope they were swayed well, by me, I suppose, because, you know, I had done, you know, I had sought out the information. I had, you know, educated myself the best of my ability. I was very, very, very mindful of the dangers and the pitfalls of maybe sometimes seeking information from the internet or from community groups. So I made sure I used reputable, you know, organizations to seek that advice. And I think when they heard my argument, and they could see that I was very passionate about it, and they could see that I really, the first treatment option really just didn't suit my lifestyle. I think when they realized that I had, that I was knowledgeable and that I had given this an awful lot of thought, that this wasn't something that I just decided, I think that's what swayed it, you know.
Yeah, clear. Great. And just on the point of misinformation, you alluded to it because there's a lot out there on the internet. How do you feel patients can really navigate that in an effective way? What was your sort of trick, if you like?
I suppose I was very, very mindful of where the information was coming from all the time. You know, as Jodie said earlier, it'd be wonderful if we had a piece of, if we had a document that we could go to, or if I had somewhere where I would have gotten all that information and it was reputable and I could have trusted it and stood by it. But unfortunately, that wasn't the case for me. So I just had to be very, very, very careful by making sure I went to reputable websites, that I went to various maybe cardiac charities that were well known, and, you know, things like the NHS Direct, for instance, here in the UK and Ireland. Organizations like that. I went to community groups, yes, and that's where I got the most valuable information, but I had to be mindful that this was people's personal opinion and maybe not always necessarily fact. And I think once I based that at the back of my mind, you are extremely vulnerable in this situation too, you know, and I was extremely vulnerable, and it was a complicating factor on my part was that it was COVID-19 was, the incidence of COVID-19 were very high at the time. So I was an inpatient in hospital and alone, and with nobody really to have a face-to-face conversation with to tease these things out. But luckily for me, I stumbled across the right community group at the right time with the right person there to guide me, and I was very fortunate, and I don't doubt that for a minute.
Excellent, excellent. This brings me to a question actually for Jodie. How can we encourage clinicians to actually refer patients to local community groups, to patient organisations and so on, as a standard practice, if you like, to get that kind of peer support, to get those insights from people who kindred spirits going through the same experience?
Well, that would be ideal. And I don't think there's one answer to that, because so many health systems and clinicians are very different. As Sandra Locke was saying, the cultures can vary vastly. And also a lot of hospitals and clinicians feel very comfortable using their own resources and information, but they don't feel as confident about using a patient advocacy organization's resources. And you do have to be careful with community groups, because not all materials and resources coming from community groups, as Sandra was just saying, are reliable. They can be someone's perspective. So you need to look at, you know, whether they're medically reviewed. Do they have a medical advisory board who is medically reviewing and writing some of the materials they have as well? We do it in conjunction with healthcare professionals. Always, it's a patient or patients and caregivers and healthcare professionals together. But one of the things that, and also I think that oftentimes they don't understand how much of an impact peer support can make. And so they're hesitant about that because they don't know, is this something beneficial? Even though it's evidence-based in mental health services, it's not evidence-based for chronic disease. So one of the ways to get them to understand this is, and I think that Sandra Locke pointed this out well, is the benefits of empowerment. And so the educational material that is put out all over the place isn't going to empower patients. What empowers patients is other patients and patient resources, patient-driven, patient perspective. Like if Sandra could have heard from someone, a short video of someone who was younger and making that decision, how impactful might that have been for her? And that's not just a simple educational piece, but that's an empowerment piece, which is a very different thing. So the ones that do use it, I will say we use them as models. We say, look, these people refer to us in their discharge. They send people to Mended Hearts in their discharge, or these people are using our heart guide or our discussion guide as part of their practice, and this is what it's doing for them and their patients. And that is helpful. If you can have those shining examples, you can get more adoption.
Fantastic, thank you. I'm going to change tack now a little bit and come back to Sandra Lauk. Two things that struck me. The moral considerations linked to shared decision making. I'd love to get your perspective on that. And also aspects linked to diversity, equity, inclusion. We want to, the patient community should embrace everybody, should be inclusive. That's, I think, the mantra. How do we make sure that those who are perhaps vulnerable to exclusion generally also have opportunities around shared decision making? And I know I've asked you two really big questions, and I know you're going to be brief in answering them.
Oh, Nicola, such excellent questions. And I think we could spend all day debating on this. But what I hear, I think on the clinician side, that there is potentially some moral distress associated with patients making the wrong decision. And I think that does create discomfort, and also a sense that, patients may be given the impression that they can basically choose off a menu of options. And that's not what shared decision making is, right? It really is around, and I think we have to undo some of that to make sure that clinicians, I think, as you said, Jody, really understand the very positive outcomes that are associated with investment in the process, and it's not all on them. And I would really highlight the expertise of nurses as expert patient educators, as members of the heart team who can really support this in a really effective way. So I think that's one side of the bucket. And I think the other side, Nicola, as you said, is that there is a risk, as we heard from Sandra McGonigal, that this is a really vulnerable time, that those clinical vulnerabilities are further compounded by the social determinants of health. We know the effect of education, access to resources, the fact that you have to use your time, money, and effort to access some of this really puts many people at disadvantage due to a variety of reasons. So I think bringing that lens to the work that we do to make sure that we always have to ground some of these big changes that we're talking about today in ensuring equity. So looking at the role of, again, I'll highlight the expertise of nurses to accompany patients along some of this pathway and work closely with physician colleagues. Looking at, as you said, the availability of resources in various languages, different approaches, I think is another piece. And I think that awareness that shared decision-making could come with a burden for the patients to feel like, not only do I have to manage my disease, but now I have to be like a super advocate, and this could turn into a full-time job. And we know that from the cancer literature, for example. And
so I guess it's the honesty, isn't it, as well, and clarity around all of that.
Yeah, so those two aspects I think are important.
Super, thank you very much. I'd like to jump back to you, Nina, and you did allude to it, but any more thoughts on shared decision making at later stages of the patient journey? Because you did make it clear that you're sort of like navigating a ship and you're taking different turns, and later on, what are the thoughts, what are the reflections around shared decision making beyond the diagnosis and initial treatment?
Yeah, as I said, unfortunately, although the treatment is the interventions and is the only solution, it creates a new problem in a way. They are anyway patients again subjected to other complication, infection. They still have to be under regular checks and indeed take medication most of the time. So I think it's very important to maintain the trust also possibly with the same person after all. And also adapt every time the expectation. Of course, if we start very young patient, it will evolve very much over time. But even much older patient could have all new needs, such as just undergoing another intervention or indeed adapt the medication for other comorbidities. So it's very important to maintain the path, and unfortunately it's very often also the case of a reintervention, so it creates a new moment of readapting and retaking the decisions. So it doesn't end there, and it's as important afterwards than before.
Sure. Great. Moving back then to Sandra McGonigal, as we're moving towards the end of the session, unfortunately, but what would your advice be to patients and carers listening in to build confidence in shared decision making, notwithstanding some of the caveats we've heard? It's clearly the right way to go. How can we build confidence in individuals to pursue that route as effectively as obviously you've done, Sandra?
Well, I guess time to do your own personal research, from those reputable sites that we talked about, but also then just having that open and honest discussion with your healthcare providers, because that's key, really. At the end of the day, the cardiologists, the nurses, the thoracic surgeons, they are the experts in this field, and we must trust them. And at any point did I, not trust the team that were looking after me. But don't be afraid to have that open, honest conversation and empower yourself. Go to the reputable community groups, go to the reputable sites, get the knowledge on board, educate yourself, talk to family, talk to friends. And then it comes down to trust as well, trusting your healthcare provider.
Sure.
And they're wonderful. They're wonderful.
And you mentioned family and friends. I mean, what sort of role did they play in supporting that journey for you? Obviously, you talk to them as well, but it would be interesting again for listeners to understand that a little bit more.
Well, I suppose my story is a little bit different because I was an inpatient in hospital waiting for the valve replacement, and it was the height of COVID-19, and unfortunately I couldn't have any visitors. So I didn't have that face-to-face conversation. Maybe with family, I was maybe trying to protect them a little bit, because we were already going through enough with me not being in the family home and in hospital waiting for surgery. So maybe the family were protected a little bit from those conversations, but definitely friends. I would have definitely shared my worries, my concerns. I didn't always want an answer from them, but maybe that soundboard. Sure. And a lot of the time when you're having these conversations with people, you're speaking out loud and you're kind of processing and making sense of that information yourself. So I would highly recommend, again, it's the open and the honesty. It's a scary time, it's a vulnerable time, and it's okay to share that with people. People will understand. And I would highly recommend family and friends involvement, those that you trust, of course.
Sure. Great. Unfortunately, we are really coming towards the end of the session and this has flown by. But I'd really like to invite all of you. We've talked a lot about a lot of different topics. I'd love to hear from each of you one takeaway, one big message that struck you during the course of the last hour's conversation in about a minute or so. And can I kick off, first of all, with Sandra Lau, with your thoughts, please?
I think it's clear from this session that the tide is turning, that we have our work cut out, but the culture shift has started. And I think it bodes on all of us as this kind of the big heart team of patients and carers, and the clinical team, but also policymakers and administration to work together towards this goal. And I'm very excited to hear the momentum that we collectively have on this area.
Terrific. Thank you, Sandra. Over to Jodie then.
I think the main takeaway or the main message that I'd like to end with is that patients have something very valuable, and that is information about themselves. They may not have a medical degree, but they have a YOU degree. So you have a degree and you know yourself best. And don't be afraid to make sure that the decisions you make and the things that you choose are right for you. And if you don't like it, keep asking until you get the information and answers you need.
Great, really very clear message. Thank you. Thank you, Jodie. Nina, thoughts from your perspective?
So speaking from the clinicians, I think I would like to stress one more time that I'm sure that despite the difference, each clinician really wants to make the journey with the patient. So maybe there are things to be changed. Certainly there are things to be changed, but we're really willing to do. And I think the importance of doing the journey together is crucial. And therefore we just have to work together to make it in the best way. And I'm sure the European Society of Cardiology, but also each and every clinician is open for that, especially if indeed it's clear from the patient this need.
Great. We have a little tiny bit more time, so I'm going to come back with one other question to you, because we sort of explored it in brief, but the role of nurses. Can you just summarize what you see as the role of nurses in shared decision making, again from your perspective as a cardiologist?
No, well, that changed also a lot in the last years. We especially invested a lot in specialized nurses that actually does outpatient clinic. So at the beginning, we involved them mainly in the post-intervention pathway, because we thought it was the most standardized and the easiest to follow. And we saw really great results. There was constant contact, really trust, connection, always supervised in a way, but very, very useful. So now we are implementing them also in the pre-intervention part. So I really see great future there, certainly.
Fantastic, great. And coming back to Sandra McCognell, can you give me a little bit of feedback as well, your big takeaway, the clear messages you'd like to convey to participants, people listening in and watching today?
Yeah, I think one of the main takeaways for me today is, as somebody already stated, the tide is turning, and that is positive. And it might take us a little while, but I hope in the future that my story won't be that unusual. As somebody who will probably face future surgeries, I'm delighted that, maybe the next time round, the journey won't be, I don't want to use the term difficult, but so I'm glad to see that things are changing. My key message to people who are facing the same situation as I did is just to talk. It's just to find out what your options are and to talk to your healthcare providers. Educate yourself as much as you can, and there is an awful pressure in that, but talk to the experts. We must trust them, we must have faith in them. And as Jodie said, if there's something that's niggling at you that you're not happy about it, just keep going. Don't accept if you're not happy, but we have to have faith and we have to have trust in our healthcare providers.
Fantastic. I think that's rounded up our session very nicely, and the message, the very clear message that the tide is turning. And I think the work of the Global Heart Hub and the Heart Valve Council is definitely contributing to this shift in opinion across the spectrum of different stakeholders that need to be involved in shared decision making. So a big thank you from myself as moderator to all of you. It's been an excellent discussion, fantastic panel, and thank you for sharing your insights, your wisdom, your experience and your expertise so openly. I've really appreciated that, and I know that the participants will as well. So let's now watch together a brief video from the recent heart valve disease awareness campaign, and then there'll be a little break, and then I would invite you to actually attend the final session of the summit on a really, really important topic as well, how patients can really achieve political impact. So don't go away, do go along to the final session of the Unite Summit. And once again, thank you all very, very much.